combined conference that we have with our partners from Valley Children's. So as we all know, maternal sepsis is a major cause for maternal morbidity and mortality. And it affects a lot of pregnant women, not only during pregnancy, in the early stages, when they're in labor, afterwards, postpartum. And as a combined collaborative with Dr. Hernandez, Dr. Hole, and our other team members from Valley Children's, we are in the process of this we're sort of rewriting the policies and creating workflows to deal with maternal sepsis. Uh, just to give a perspective to everyone, last year here at Sierra View, we had 22 patients that met sepsis criteria during or around pregnancy. So the problem is real, the problem is here, and any one of us could be facing it or dealing with it at any given time. So this is something that we all need, and it's for our own patients' safety. So that being said, I'll give the floor to Dr. Hernandez, and he's going to get started.
Perfect. Hello, good evening, and thanks for all of you being here and share this night with us. Okay, so even though tonight Dr. Hall is going to be the main speaker talking about maternal sepsis, I just want to maybe put some context as to why we are here, why we are doing all this, and why this is also relevant for all of us. So everything starts with healthcare, right? And my intent tonight is not to discuss the goods and the not so good things about our healthcare system, but definitely has to do with that, and that's what is gonna lead us to why we're here tonight. So we have the most expensive healthcare system in the world, right? We all know that. As for GDP, you can see our percentage. This slide is a little old. It was from 2018, but I wanted to show it to you because you see here what is the projected expenditure to 2027. So what's really important is that 19.4% in 2027 is happening right now in 2023. Okay, so these projections are not only real, are even worse, right? So we are spending a lot of money in healthcare. Definitely we are at the leading edge in medical innovation, in technology, R&D for pharmaceuticals, but still we have a problem in terms of public health and healthcare outcomes when we compare ourselves to our peers, right? So just to show you here, so money spent, United States, and then I want you to pay attention to Germany, Sweden, and the UK, right? So we're almost double or we double the amount of money that we spend, especially when we do as a GDP for comparison, right? Because we're a bigger country, we're more people, right? Say, hey, of course we spend more money, but when we compare our percent of GDP spend, then it makes sense that we can compare oranges and oranges, right? So, but then what happens is that even though we spend a lot of money and we are the leading edge in technology and all that, healthcare, we are mediocre at best, okay? So when we see the rates for infant death, right? When we compare, when I said the UK, Germany, Sweden, we are more than double, right? Maternal mortality, which what also is very important for us, we are like sky high when we compare again Sweden, Germany, the UK. So definitely it tells us that there is a problem, okay? And again, the intent tonight is not to discuss that, it's not to solve this huge problem, but at least there are things that we can do locally in our hospitals, in our communities, okay? So there's maternal mortality again, that this is across all the population, right? Total, we have here from 2018 to 2021, total, all of them on the rise, on all ethnic groups, okay? So there's only some ethnic groups across the board. All females are experiencing an increase in mortality across the United States, okay? But the most important part about that is that 4 out of 5 pregnancy-related maternal deaths are preventable, okay? And that's why we're here. Why we know that? So every state, they report reviews, okay? And then the CDC gets the data, and then that's reported from data from 2017 to 2019. Okay, 4 out of 5. Okay, so this problem has been going on for more than 15 years now. So the government, Department of Health, granted a collaboration and some funding to ACOG. And then ACOG in 2014 implemented the Alliance for Innovation on Maternal Health. Essentially, it is a national data-driven maternal safety and quality improvement initiative based on interdisciplinary consensus-based practices to improving maternal safety and outcomes. Okay, so essentially this is being worked since 2014, and the Department of Health has been renewing this collaboration and the funding. Last time they did it was actually last year. So this has been going on. So then this program provides implementation and data to support for the adoption of evidence-based patient safety bundles, okay? So essentially this alliance works with state teams and health systems to align at the national, at the state, and the hospital level engagement efforts to improve overall maternal health outcomes, okay? Here in California, we have the California Maternal Quality Care Collaborative, the CMQCC, okay? And the way it is done, so these patient safety bundles have been developed, and they contain the best practices to address certain maternal conditions that carry the most mortality, right? So, and then with these bundles, it is supported by sharing data to maternal data centers. And then there's some metrics that are used and measures through those data centers to monitor what's going on and then monitor improvements, okay? And they, again, they address the leading known causes for preventable morbidity and mortality, maternal morbidity and mortality in the United States. So these bundles are for obstetrical hemorrhage, hypertensive disorder of pregnancy, sepsis in obstetrical care, safe reduction in primary cesarean birth, cardiac condition in obstetrical care, care for pregnant and postpartum people with substance abuse or use, perinatal mental health condition, and postpartum discharge transition. So all these bundles are available, are free, are there to use, to be implemented, okay? So, and these bundles, essentially what they try to create is a quality improvement framework in which the units are ready to handle an emergency, to easily and recognize fast and response to those emergencies in a timely fashion, and then after that, report those outcomes to the maternal data center, right? And then also, this framework provides information that regulators will ask, especially the Joint Commission and the CMS, about performance for these elements. So these bundles provide standardization within the evidence-based policies and procedures, and then education for patients, staff, providers, information about drills, because this is a continuous education effort and reinforcement, and then also provide a framework for case reviews and role-specific education. Okay, so it's very comprehensive. Okay, so thinking about what we can do in our communities, so part of our mission in Valley Children's is to provide high quality care and comprehensive care to all children. But everything starts from a healthy pregnancy, right? So using a program that's been already in place that Valley Children's has to support other organizations. This is a clinical partnership program. So we had the initiative to then start addressing this need because we know that we need to do our part for our communities and for our patients, right? And then taking advantage of the good relationship that we have between Children's and Sierra View Medical Center. So we decided to start these efforts to try to provide support and then improve, because at the end, we do this for patients, for our communities, but also organizations will need to be in compliance in order to continue working properly and be in compliance with the regulators. Okay, so just to give some examples, for fiscal year 2023, the Hospital Inpatient Prospective Payment System announced critical steps to improve this maternal health by supporting this high quality and equitable information and support for the pregnant patients. So they are encouraging hospitals to consider the implementation of these bundles to implement best practices. President Biden signed an executive order already to establish a public reported hospital designation for hospitals that provide maternity care and can prove that they not only implemented these bundles, but also are reporting data, okay? And then they will be required participation in these efforts in order to be then eligible for future financial help, or maybe it's gonna be tied to reimbursements in the future if the organization receives Medicare funding. So this is going to be turned real. So everyone who is participating in maternity care and want to continue to be in compliance with all that, we need to implement all these bundles. Okay. So with the clinical partnership, so we want to make this become an organizational priority and to guide, decision making and resource allocation. The beauty of all these efforts is that it's essentially free. There's no additional investment of funding, of money. So the current resources that organization has, you just allocate them in the right place and then just provide leadership and then commitment from everyone, from all the providers, the staff, the non-clinical staff, everyone. So it's easy to do. It's just, have the commitment to implement and then to report. And yeah, so that is the good thing about that. So that helps organize interventions into standardized clinical care pathways to reduce preventable harms. At the end, that's our goal. Okay. So I hope that with that you understand. I put some context for these efforts, and then with that, I'm gonna just let Dr. Hall educate us about maternal sepsis.
Hi, I'm James Hole, and I am Director of Maternal Fetal Medicine here at Valley Children's. You've already met and heard from Dr. Hernandez, who is the Director of our high-risk prenatal care and delivery department. Many people ask why a children's hospital has a maternal fetal medicine group, and basically it's pretty much for what Dr. Hernandez said, which is if we're going to start, if we're going to get the best outcome for babies, we need to start in prenatal care, as everybody knows. But for any of us who do maternal fetal medicine and obstetrics, like Dan and our high risk hospitalist laborist group, you can't separate that from maternal risk. So we're very well acquainted with the bundles and how to implement the bundles. I've implemented all of these bundles in my previous life on the East Coast in Philadelphia, including the sepsis bundle. So it's something that seems like it would be a lot of work in the beginning, but it becomes easier and easier as it progresses. Many of you might know some of the names that you're looking at there: Ron Gibbs, Elliot Main, Melissa Bauer. That's a combination of internal medicine, OB, and anesthesia who came together. The other thing that I find interesting is that while the rest of the country loves to criticize California for a ton of things, most states use a variation of the CMQCC quality recommendations in their own bundles. So while they can criticize what they want, our ability to collect data and to analyze that and put it out makes a huge difference. Go ahead and go to slide 3, if you don't mind. Whoever's advancing the slides. Is it me or?
Yeah, can you see it?
I can see it. I would say go ahead and advance it to number 3.
Is it on number 3 for you?
No,
No. What slide do you?
I see the very first one.
Oh, that's great.
But that's okay. If I can describe, if I know slide 3 is up, I'm looking at it, I can tell you.
Let me try one more thing. I don't think that's gonna help. Pen and laser. I don't know how to get it out of this presentation mode.
Can I stop sharing and start it?
It should still be logged in. Yeah, he can't see the screen. In IT.
I can just see the one slide. That is slide 2, I believe.
You see slide 2. We see slide 3.
There's slide 3 right there.
Can somebody click on the keyboard? Go back to slide 2. Can you see that we're on slide 2?
Yep.
Okay, go back forward to slide 3. Okay, so it's moving for you now? Perfect.
Yep, perfect. All right, just a quick talk of the acknowledgement, because I think that it's really important. And if you take a look, you will see a very diverse group of people from all over the state. A diverse group of everybody from PharmDs to PhDs to nursing, and a nice variety of hospitals across the state. So this isn't any one person's opinion in what's going on. Of note, which we're very happy with, if you look down on the left side of the screen, you'll see William Gilbert, MFM Sutter Health. Bill also is works for Valley Children's, and we use his expertise a lot. Next slide. I don't know if this is available for credit or not, but here's the learning objectives. The importance of sepsis on morbidity and mortality. What we like to describe as the 2-step method for screening and then diagnosing. Probably a really important take-home point here is the pregnancy-related differences in vitals and labs, and then how to approach treatment recommendations. And then we can discuss a little bit about how you guys would like to begin implementation. Go to slide number 6, please. 7, try. There we go. Nope, okay, you can leave it right there. Go back one, please. And nope, that's good. So you can go ahead one. Okay, I'm going to give everybody a quick case presentation. I like to do it here to give everybody a chance to think about things. This is a 26-year-old G2P1. She's hospitalized with preterm prom at 32 weeks. On hospital day 8, she'd be 33-1. She felt kind of warm with her heart racing. But her vitals, if you look, her temp's just 97.8. Her heart rate is 130. Her respers are 22. Her BP is 115/62. And the fetal heart rate's 160. She's contracting every 3 minutes, and her exam is 380 and -1. Labs are drawn. She's got a white blood cell count of 22,000. She was given steroids when she was first admitted. She's watched. She's on the monitor. 2 hours later, she has a repeat cesarean for non-reassuring testing. And then we'll get back to this case. Okay. So sepsis occurs in about 0.04% of all deliveries. And it is one of the leading causes of maternal death. Most cases of maternal death from sepsis, notice I'm not saying that sepsis is necessarily preventable, but most cases of death can be prevented. And for each maternal death from sepsis, 50 women experience significant and life-threatening morbidity. Next slide, please. Okay. If we take a look, this is actually back from 2017, which was when they started putting this bundle together. If you look at the current CDC data, there are some differences here. And I don't know if anybody can guess what is now the number one cause of pregnancy-related maternal mortality in the United States. Can anybody guess? And it's okay if nobody wants to. It's actually not on this list. The number one cause now is mental health. And if you notice, you're reading more and more articles about mental health, both prenatally and postpartum depression, because suicide, overdose, and poisoning from medication, non-prescription medication use, other drugs, it now accounts for 23% of the pregnancy-related mortality. If we get to this list, infection, thankfully, is no longer number one, as it evidenced on the list. It's actually down to number 4, which is superb. The largest cause now of maternal death is hemorrhage, which has gone up from 11% to 14%. Cardiovascular conditions have come down a little bit. That's number 3 to 13%. Infection is now number 4 and has come down to 9%. These are statistics from a year ago. What can be attributed to those things? The hemorrhage-related aspect can have a significant number of potential reasons, some of which are preventable, some are not. The biggest reason is invasive placentation, placenta accreta spectrum, because of the increasing number of C-sections. The decrease in the death rate from infection and from cardiovascular related events is because of bundles. There are bundles that, if you remember from what Dr. Hernandez showed, for each of these. And each of these should be able to bring down risks, but indeed, they have come down. Pulmonary embolism, unfortunately, hasn't changed, because that is a very difficult to predict event for most people. Hypertensive disorders have decreased, cardiovascular has decreased, infection has decreased, hemorrhage has increased. And that is the one thing that we can continue to lower. Next slide. So, what are the leading causes of maternal sepsis? And we tend to think of it mostly as antepartum or postpartum, but indeed there is a significant risk of post-discharge maternal sepsis. And I'm not going to read through the slide, there, but if you look at it, the ones we definitely think about are choreo intraamniotic infection. We all worry about influenza pneumonia, COVID pneumonia. The septic abortion, we've really kind of let that one out of our thought process, although in many states, they're going to have to start considering this because of changes that they've made in their laws regarding the potential for something being considered a termination. For intrapartum, obviously choreo, pyelo, endometritis, which we know. Unfortunately, necrotizing fasciitis and wound infection is increasing. And I'm sure we can all think about why that might be occurring, and that has to do with BMIs. And there's a tremendous amount of research being done now on what is the best way to prevent post-cesarean wound morbidity, especially as we get into BMIs of upper 50s, 60s, and 70s. So next slide. The one clinical pearl that is important, and when I talk to residents or I talk to other physicians, it is critical that we recognize the potential for sepsis. We begin treatment immediately. If we are waiting for a mom to show signs that are clearly consistent with sepsis, we are going to lose moms because it's then too late to begin therapy for everybody. So what we're going to get into here, what are some of the things we can look for that help us understand it in pregnancy? Next, please. All right. So using a diagnosis of sepsis in pregnancy is difficult because, as we know, there are physiologic changes that can mimic sepsis. Heart rate, the blood pressure, white blood cell count, and increased lactate levels in labor. We'll talk about that in a minute. Most hospitals now have running in the background sepsis risk assessments in any type of computerized system that they may have. Cerner has it, Epic can have it, and other ones. But the criteria for sepsis in non-pregnant women don't perform well in pregnant women. Indeed, it can result in a huge amount of false sepsis alerts. And of course, it's the person who cried wolf, the child who cried wolf. The more that those fire and it's not sepsis, the less people are going to believe in it. And so we get into a situation of we need to limit the false alarms. And then obviously, pregnant women we know are at increased risk for severe outcomes. And it's not just influenza, it's any sepsis system, because of the changes in their physiology, makes them more likely to have more significant sequelae. Next, please. All right. If you go back to 2016, you may have all remembered that there were, in the past, you probably heard a lot of different things, whether that would be bacteremia or SIRS, systemic inflammatory response syndrome, then septic shock or sepsis. Based on the guidelines, they really like to use two terms. Sepsis, which does not require the identification or isolation of any organism. And so when coding for sepsis or putting a diagnosis for sepsis, it's anything where there was life-threatening organ dysfunction caused by a host response to infection. Then there is septic shock, where it's a subset where there are underlying circulatory and cellular metabolisms due to oxygenation, due to blood flow, perfusion that are profound enough to increase mortality. So we can go, next slide. So if you look, there used to be severe sepsis, which was sepsis plus end organ. We really don't use that term anymore. Sepsis itself involves some degree of end organ dysfunction, so we actually don't use severe sepsis. We use sepsis and septic shock. All right, next. And you can slip ahead one more. All right. Current screenings don't work. And the reason, as we know, is that white counts are elevated. A white count for a pregnant woman that is completely normal in labor or just being admitted to the floor is abnormal for somebody else. Respiratory rates can be normal in pregnancy because of the increased respiratory rate just that occurs physiologically with pregnancy. So we like to talk, the CMQCC recommended a two-step approach. The first step is simply limited to vital signs that are adjusted for pregnancy in the most recent white count, which is within 24 hours. The second uses evaluation for end organ injury, okay? Now, part of the problem here is lactic acid is extremely useful for evidence of perfusion issues and end organ issues. It is difficult to know whether doing that during labor is we can use, especially when somebody gets to second stage and pushing. We order it, but if it is elevated, we want to be very careful we don't over-respond. But that doesn't mean that lactate levels antepartum or postpartum are not useful. They're still extremely useful. Next, please. So as I said, the two-step approach, rather than an alarm going off in a computerized system, aims to reduce the false positives, alarm fatigue, but not to miss cases or to limit your false negatives. Again, it is based on clinical data from 3 hospital systems. And so it involves a screening step followed by a confirmatory step. I will tell you, when I implemented this, when my hospital system, a 7-hospital system outside of Philadelphia, when we put in Epic, we found that we were able to decrease our false positive rate in calling potential sepsis cases by about 75% by putting in pregnancy specific values. So the next one would be, next slide, please. Pregnancy adjusted vitals using 2 standard deviations from the mean. You've got to be above 38.1 centigrade for it to be a temp. Your heart rate has to be above 107 beats per minute, and the respiratory rate needs to be greater than 24 breaths per minute. And if you're on a typical floor and somebody's tacking at 100 beats per minute, their respiratory rate is 22, and they have a temperature of 38 or above, that's going to fire a sepsis alert. So the next part simply means that patients meeting these thresholds would only occur 2.5% of the time. And so we would hope that we would be at 2.5% or less of patients are going to fire off an alert just because of physiology rather than infection. The next slide is a very, very busy slide. We're going to go through it part by part, but that is something that can be pulled off of the slide deck and blown up. And what I would recommend is that is done and is put up in an area that's easily accessible to look at in labor and delivery, a postpartum floor, and an antepartum floor. Okay, so step one. What is the initial screen? We want to see what the temp is, less than 36 or greater than 38. Is their heart rate greater than 110? Is their respiratory rate greater than 24? And what does their white blood cell count look like? It's got to be greater than 15,000 or less than 4,000 or greater than 10% bands. If you have 2 out of any 4 of those criteria, your sepsis screen is positive, and that calls for further evaluation and further action. What do? If you suspect an infection, you do not wait for further evidence. You give them a 30 milliliter per kilogram fluid load. That 1 to 2 liters is not particularly useful. It's much more appropriate to give them a bolus of 30 milliliters per kilogram. If you've got somebody that is 200 kilograms, that's a lot of fluid that you're going to give. So it's important to remember that 30 ml per kilogram. So 2 out of 4, you're going to give them a fluid bolus, and you are going to start either source directed or empiric antibiotics. Then we move to evaluation of end organ injury, which is the next slide. We get a CBC if it hasn't been done. We want to look at their coagulation status, PT-INR, PTT. We definitely want a CMP. Specifically, we want to look at, are we showing evidence not just of liver inflammation, transaminitis, but are we seeing signs of hepatic dysfunction, which is a rising bilirubin level? The same thing for urine. We want a creatinine. Decreased urine output can happen when somebody's postpartum or intrapartum or simply dehydrated. And then we want a venous lactic acid. Anybody who meets the screening criteria needs to get a lactate level. And then obviously urine output, you want to put the Foley in, you want to do pulse oximetry, and you want to look at their mental status. This means waking a woman up if you're finding this, if she's sleeping. I know we don't like to, especially when they're postpartum, but are they mentating normally? Are they showing signs that maybe they're not getting quite as much perfusion to the brain as is needed because of organ dysfunction? Next slide. So, what are we looking for? Acute respiratory failure. We're looking for, is there a problem with coagulation, platelets less than 100, an INR or a PTT starting to show prolongation? Liver function, are we not conjugating bilirubin well enough? Cardiovascular function, if you remember, I said we give a fluid bolus generally on somebody who is morbidly obese. If you do a calculation on somebody who's got a BMI of 150, you don't want to start with a 3-liter bolus, but you want to go at least a liter or more. And you want to see what their response is. If after a fluid load, they're systolic and less than 85, or their mean arterial pressure is less than 65. We want to be recording that. Or if they were preeclamptic and they were initially running a blood pressure of 150, which doesn't require emergent blood pressure treatment. If you see that drop by 40, that is an inadequate response to fluid. Renal function would either be a doubling of their serum creatinine or a creatinine above 1.2, or if you notice, a urine output that is less than 0.5 mLs per kilogram per hour for 2 hours, which means do they remain oliguric despite their fluid bolus? Mental status, as we said, agitation, confusion, can you not wake them up easily? And then lactic acid. In the absence of labor, greater than 2 millimoles per liter is an extremely worrisome sign. Personally, I don't use it in labor. It can be difficult to assess. If a patient ends up in the unit, they generally get it, but the other signs are much more utilitarian in labor. So notice you only need one of these. So if you have a screen positive patient and then you give them their fluid bolus, because you're supposed to do that on everybody, you started antibiotics, but you don't get an appropriate systemic response, you've got end organ injury, and your patient is getting very sick very quick. Next slide. So this is what we just talked about. So when you look at step 1 and step 2, if all criteria are negative, the group remains high risk for sepsis. You want to watch them. We'll leave out the elevated lactate in labor because I think that can be very difficult. If you have a positive screen and one positive criteria as above, you want to start antibiotics, which hopefully you've already started while you're waiting for these tests to come back, because these will take 1 to 2 hours. There is a question which we'll get to on whether you should obtain blood cultures. I like to simplify the world. I get blood cultures on anybody that has a true 2 positive sepsis screening test. It is much better to have them. If you have done the fluid bolus and the hypotension is persisting, they need to go to the unit. They do not need everything else. The reason is if you keep pouring fluids into them based on their colloid oncotic pressure, and I'm bringing back something from nursing and medical school, but colloid oncotic pressure holds the fluid in your veins, and a normal COP is about 17. If you remember from way back when in medicine, when your COP goes 4 below your wedge pressure, you get pulmonary edema. And that's where that number came from that you had to learn. In pregnancy, you can have a colloid oncotic pressure down at 13 or 14. You're going to get pulmonary edema at a much lower fluid volume than in a non-pregnant individual. So if after your fluid bolus, your patient is remaining hypotensive, that needs to be considered as starting vasopressors much more quickly. That begins a discussion that one needs to have with the intensivist, because They're not used to doing vasopressors that soon. Next slide. So how does it work? If you take the three systems, Kaiser, Sutter, and Stanford, and if you look of the population screened, these are people that began to have any symptoms. About 1.3% came out as screen positive. That is an acceptable rate using your screening system. You're not overcalling when you're not assuming anything at a 98.7% of the patients. Of those patients, 16.6% ended up with an organ injury. So it works very well with a sensitivity of 97 and a specificity of 99. So the next slide says that it's going to give you fewer missed cases, it's going to give you fewer false alarms, and it keeps your screen positive rate under 2% without missing too many patients. I will tell you that when we changed the alarms in our Epic system in Pennsylvania, and what we did was, for that specific group of people, we had nurses in our control center looking at everybody's vitals. Anytime a sepsis alert fired on a pregnant patient, it went off. The nurses looked at it. They saw they were pregnant, which meant antepartum, intrapartum, or the first 48 hours postpartum. They would then specifically apply the pregnancy criteria to see if that sepsis alert was real or not. And that is what made the difference for cutting down on our false alarms. So clinical pearls then, as we move along. Next slide. And this one's huge. Everybody in the clinical team should have a high index of suspicion and has to have non-hierarchical communications to detect impending sepsis. This is no different than anything we do in the OR with timeouts, and anybody has to say if they think something's going wrong. It's no different than what the airline people use. Anybody and everybody should be watching, should be careful, and should be empowered to speak up and know they're going to be listened to. And this boils down to, if a nurse on the floor at 2 a.m. calls and says, I don't like what I'm seeing, we're starting to get positive sepsis screening criteria, that needs to be listened to. And that's the only way we will get the number of patients we need to. Next. And you can click 2 slides ahead. All right. So what is in the looking for assessment and treatment bundles? You want to act quickly upon recognizing that there is sepsis. Remember, that's 2 screening and then 1 confirmation of end organ damage or septic shock, which is a hypotensive patient in response to the fluid bolus. We need to minimize time to treatment. Sepsis is a medical emergency, not waiting for septic shock. And the method to approach is, when that screen goes off, begin treatment, begin a fluid bolus while you're looking for everything else to cut down on those hours. Data shows that every 15 minutes after a suspicion of sepsis, that there is a delay in antibiotic and fluids, increases mortality. Monitor for lack of response, and you really want to make sure that during physician handoff or nursing handoffs, during shift change or call change, the sepsis status is specifically mentioned during bedside care. Okay, next one, next slide. So screen positive with end organ injury, source-directed antibiotics, you note if not already started. If the source is unclear, we'll do broad-spectrum antibiotics. We'll talk about that. Increase the fluids to 30 mLs per kilogram if not already done. If you haven't done a lactate, do it. Blood cultures if not already done. If you notice, I will start drawing them on anybody that has 2 screen positives, because if you notice, temp is not 100% part of them all. You don't need to have a temp to have the positive sepsis screen go off. And then if you are concerned and if something is really making alarms go off, you want a rapid response team called. I would rather call the rapid response team and tell them to go away. If it doesn't work out, I would rather start antibiotics and stop it, and start a fluid bolus and stop it if things don't work out. So if you follow an initial sepsis screen, here's what is recommended. They get, if they're still pregnant, you want a fetal monitor on them. It's an extremely useful critical care tool, because if that baby out of the blue starts having late D cells, you know her cardiac output is dropped by at least 25 to 50%. You want to put a pulse ox on them. You want blood pressures at least every 30 minutes. You want a temp every 30 minutes. You want a urine output, and you want to be continually assessing their mental status. That is a hint that you don't start this stuff and then a nurse has to go take care of other patients for an hour. And that is something that can be difficult for some units where there are staffing issues. You need somebody checking in on this patient usually at least every 15 minutes if somebody's not with them continuously. And then you can see when you continue it too. All right. So for cultures, for choreo or intraamniotic infection and endometritis, rarely do we do lower genital tract cultures, because really what you're going to find are vaginal contamination organisms. There is one exception to this, and that is if you are concerned that a patient actually has a variation of toxic shock syndrome. This will be mostly occurring when a patient comes in with signs of sepsis. You can't find it. They're 24 weeks, 23 weeks, and they look like they meet criteria for toxic shock. You always have to consider group A strep toxic shock. That is the one time that I will do a vaginal culture to see if they're a group A, not group B, but a group A strep carrier. Cultures, you're going to begin treatment without waiting for cultures. Generally, we use that to see if later on we want to narrow the spectrum of our antibiotics. But if patients show sign of end organ or shock, you should get blood cultures. Like I said, I find it easiest that when I am doing blood work on a patient who has had a double screen positive, when they're drawing that first set of lab work, I grab blood cultures at the time. Next. Yes. So if you're going to do blood cultures, you want to try to get them before antibiotic administration. So one part of the bundle is saying, well, maybe they won't do good, but if you're going to do them, you want to get them antibiotics, but you want to begin antibiotics in suspected sepsis and shock. Again, I get them. You want anaerobes and aerobes to be drawn. We'll talk a minute, but when you get to sepsis, It is very rare to be a monomicrobial infection. It is way more common to be polymicrobial with a mixture of gram-positive, gram-negative, and anaerobes. Next slide. So fluid management, we talked about it, initial resuscitation when the sepsis screen fires. If they're still having problems after the initial fluid bolus, we need to start figuring out, are we going to do further assessment of fluid status? This is generally done in some rapid response teams can do it. Basically, you're looking at vena cava filling. We do it. It's not well studied in pregnancy, mostly because if you're trying to look at vena cava collapse, filling, and emptying, what happens when you put a pregnant lady on her back to vena cava? It's going to look low very frequently because you're going to impede blood flow coming back. So it may not be quite as useful. When do we want to transfer them to a higher level of care? Next slide. Persistent hypotension, we talked about this, or if you need vasopressors, higher level of care doesn't mean just to your intensive care unit. Higher level of care will generally mean if the intensivist doesn't have significant experience in dealing with a antepartum, intrapartum, or immediately postpartum pregnant patient with sepsis or septic shock, you really want to think about transferring them to a higher level of care institution. Obviously, persistent hypoxia or altered mental status that won't come back. Okay. Do you guys have a rapid response team in the hospital?
Yes.
Okay, good. Generally, it's going to be, especially at night, a critical care nurse and a respiratory therapist. Outside of the emergency room and intensive care departments, that's where they use it. However, if you think about it, if your rapid response team is not familiar with all the principles we're talking about here, they can't do an adequate job. It's not their fault. But unless they're educated on the differences in our patients from the patients they see every day, we need to know. So I would recommend in the hospital that specific training be given to your RRT to help make things more appropriate in their assistance in their diagnosis. Next slide. Who goes to the unit? Anybody that is determined to be clinically unstable. It can be a multidisciplinary team. Generally, that's what works best. But again, if your intensivist doesn't understand pregnant septic shock criteria or pregnant sepsis criteria and why we worry earlier, it can be difficult. Education is huge. If you're going to transport the mom, obviously you're going to need a team, not just an ambulance, because you're going to want to do cardiac monitoring, pulse oximetry, somebody that's able to maintain their venous access and give fluids. If mom meets septic shock criteria, just because you can't monitor the fetus doesn't mean you don't ship the mom. Babies should never win over mom. Obviously, you'd love to be able to monitor the fetus, especially if the baby's premature. But remember, monitoring at 25-weeker may not be as important as just getting mom to an institution that can care for her. And again, Stabilizing mom will often stabilize the fetus. Obviously, this won't work in a choreo or an intraamniotic infection, but if you're talking pneumonia, if you're talking pyelonephritis, it can make a huge difference. Additional things that they talk about, norepinephrine is the pressure of choice in pregnancy. Again, this is something that you want to have your intensivist know. Why is norepinephrine the pressure of choice? Because it does not decrease uterine blood flow if they're still pregnant. So we go right to norepinephrine. If you need some kind of cardiac support, we use dobutamine because it will directly increase cardiac output. Glucose control, avoid hyperglycemia. Hyperglycemia worsens the outcome in sepsis. You need to give, most places will do boluses of insulin to bring it down, unless your patient's a diabetic when they might need an insulin drip. You definitely want to use a cooling blanket if you've got significant hyperpyrexia, or if the mom has a very low temperature. Remember, if her temperature was below 96, that worried you. You want to use warming blankets. If the mom is premature, baby doesn't need to be delivered instantly. Please give steroids. There is no reason to hold on steroids. It's not going to make things worse. And obviously, you want to remember both mechanical and pharmacologic VTE prophylaxis. Everybody can get pneumatic compression devices. Obviously, if a patient has gone into a DIC, you really want to avoid giving heparin, but everybody should at least get mechanical devices. Okay, next. Next slide. Okay, so assessment and treatment, antibiotics. Start them. As soon as you are worried, you want to start them. The initial choice of antibiotics is usually empiric, and then you want to use something broad spectrum. Then you assess for source, and you can then narrow your spectrum. So you want to look at their wound. You want to look at, do they have an abscess? Do they have urinary obstruction? Did a ureter get somehow involved? And you want to do all of that while you're looking for your source. Next slide. So again, as information becomes available, blood cultures, wound cultures, urine cultures, very rarely do we get sputum cultures that help us all. You can narrow the spectrum, but remember, pelvic infections are usually polymicrobial. So cultures from the genital site may or may not be collected. Again, like I said, in some instances, I do it when I'm worried about very specific things. Next. Okay, do you guys have antibiotograms? Yeah, less and less hospitals do, unfortunately. That's the little booklet they give you that tells you for each of possible organisms, what is the more common resistance patterns in your hospital. Again, less and less are using them. Patients that have been in the hospital are much more likely to have MRSA or ESBL organisms. So you want to start antibiotics as quickly as possible. And generally, you'd like to have a sepsis order set. Next slide. Again, this one I bring up again because of obesity. Moist wounds that aren't allowed to get to air and aren't healing well are generally how this occurs. It can happen in anybody. It's much more common in diabetics, but it means remove the dressing. Look, Doesn't matter if the patient's got a wound vac on. Take it off and look to make sure you're not seeing any of the signs there, because that is going to require very fast and very extensive debridement. Okay, so the next regimen is antibiotics. Next slide. So this is just a sample, so please don't use this right off in your hospital. If you think you've got chorioamnionitis or an intraamniotic infection, generally what you're going to use is AMP, GENT, and almost every place now adds metronidazole to that. Other places, and again, this would be based on what you're seeing on resistance studies in your hospital, can use ampicillin sulbactam, piperacillin tazobactam, which is Zosyn, or cefoxitin with. More and more places now will be using either AMP, GENT, and Flagyl, or Zosyn. If you're looking at OBs and MFMs, we will often go to the AMP, GENT, and Flagyl. Most of the ID people like to go to Zosyn. It's not that one is right and one is wrong. How long do you keep it going? Sometimes some people will say that if you don't have an organism that is going to need specific culture, like a positive blood culture, you want to keep it going until all of the vital signs are normalized and they're afebrile for at least 24 hours. I don't know many people who just use 24 hours. Most people will use 48. If you think there is a chorio and you've got antibiotics started during labor, you don't have to continue antibiotics. Again, most people do. Next slide. Okay. Recommended antibiotics based on where you think things may be. That's the slide. I'm not going to really go over it. Please notice that for amniotic infection, abdominal infection, chorio, and endomyometritis, if you notice, they add plus metronidazole, plus metronidazole, plus metronidazole. And then the other ones for community-acquired pneumonia, hospital-acquired pneumonia, those are pretty straight treatments that don't have anything to do with the pregnancy itself, and you'd use what your hospital uses. If you think they are getting into a sepsis from a urinary tract infection, notice what you don't see. You don't see a simple cephalosporin, even Rocephin. This is something we commonly see. You want to go AMP and GENT, or a carbapenem, or Zosyn.
First floor cafeteria. This is the drill. Full station, first floor, cafe. This is the drill. Code red. Full station, first floor, cafeteria. This is the drill.
I thought that was something that only happened at Valley Children's. We have about 6 of those a day. So anyways, an uncomplicated urinary tract infection that isn't associated with sepsis, you're fine to use Rocephin or an antibiotic like that. But if you have a UTI plus sepsis, you're going to jump to big guns. Why? Because even though it's a UTI, you got a greater risk that it's polymicrobial. The one aspect that I like to add to this, that if you are in flu season and you have a patient that has a community-acquired pneumonia, and they are looking like they're getting sepsis from a pneumonia, you're going to want to add Tamiflu if it's flu season, okay? Because that can rapidly progress. It'll still give you sepsis, and you want to start that. Now, we just recommend that that usually be done only during the CDC recommended flu seasons. Generally, that starts September and October and runs through about March. But again, just something to think about, okay? If a patient has no improvement with initial resuscitation with antibiotics and fluid, you want to start looking for, obviously, and if this is not a patient who's critically ill in the unit, you want to start looking for things that you can help with perc drainage if there's an abscess. You want to look at calling in infectious disease to help you think of things you may not have thought about. I will give you an example. I had a patient once that was sick for 2 days. Every culture was negative. Every antibiotic we used was negative. We assumed her hepatic dysfunction.
Code red, all clear. Code red, all clear.
Good. But we assumed everything that was going on, we were going right along with the bundle. And when the idea consultant came, he said, have we thought about CMV hepatitis? I have also seen this with herpes hepatitis. And by putting on appropriate antiviral specific, we made a difference. So bringing somebody in to think out of the box can be very useful. Next. So patients with identified sources of infection that require surgery, you don't delay a DNC. If you appear to have necrotizing group A strep infection, which includes the patient I'm telling you about, I've had that, and that's why I think about the group A strep evaluation, they're going to need a hist. If they're not getting better and it appears to be a necrotizing streptococcal infection, that will generally be evaluated by a CT scan. You then need to drain, hist for that, or drain pelvic or perineal abscesses. You need to get into there, open, and drain them. If you think there's other aspects, you call a general surgeon. And again, immediately evaluate somebody if you don't like the way the wound looks. I don't know if anybody's ever seen necrotizing fasciitis, but you can mark the edges with a pen, come back in an hour, and it will have progressed. So look at the wound. You don't like it, call. Okay, next part, obstetrical considerations. This is kind of a whole separate talk in regards to when do you deliver if a patient is septic, and should you ever use neuraxial procedures. In regards to timing of delivery, next slide. It's not an immediate indication for delivery. When you do it, really needs to consider what's the gestational age. Are you going to improve maternal heat dynamics to help the baby? Do you need to section them? Not necessarily. And again, steroids are not contraindicated. This is something that I would definitely recommend, that if the baby is looking okay, they're of a near, a gestational age where the chance is reasonable the baby's going to survive, but mom is incredibly sick and not getting better as quickly as you want, I would say please give an MFM a call. It's something that we deal with and we're happy to talk you through. But why don't you need to, why shouldn't you consider neuraxial, either an epidural or a spinal? And I know your anesthesiologist is not going to be thrilled about this. You have a compromised physiologic status. The cardiovascular effects of a neuraxial block, I'm talking about the tachycardia that can come from that, the hypotension that can come from that, can significantly worsen maternal morbidity and mortality. So please, I know anesthesia doctors never want to do that, but no matter what the patient is, putting them to sleep is a safer option. Next slide. Discharge education, I'm sorry, next slide. Every woman that goes home, whether they have had an infection or not, the danger signs of sepsis should be included. That's the mental status change, that's the temperature, that's what their breathing rate is, that's what their pulse rate is, okay? And you want to obviously talk about decreasing infection risk. For women who have had sepsis and have had treatment and are being discharged, you want to make contact with them after 3 to 4 days. Okay, what is going on? How are you feeling? Have you fully recovered? Do we need to look at you again? This one includes, if they're still on antibiotics, are they taking them? We all know that they love to stop them when they start feeling better. Okay, so finally, the key clinical pearls. Next slide. Prompt recognition and rapid treatment improves outcomes with survival. We want to be careful about what kind of alarming systems we put in. I recommend either they be purely pregnancy specific, or your team that is reviewing the alarms then applies pregnancy specific criteria. With a suspected infection, if you've got a mean arterial pressure less than 65, you want to put the sepsis protocol in place. Use a two-step approach. Screen is positive if there's just 2 values. And if you have 2 of those values, you want to proceed on to step 2, which was the end organ evaluation. Any concern about a patient's clinical status and if there is infection, don't be afraid to go right to step 2. The point here is the more quickly things get done, the better. We'd like to try to limit what we do if we don't know for sure. But it is better, in my opinion, that if you have a patient that has 2 of those screens positive, it is always better to start everything and then take it back. Next slide. Two-step approach. You only get about 2% of your total patients screening positive. Early administration is important. You want to do it within an hour. That means you want to do it when your screen is positive. You're going to generally want to use broad spectrum antibiotics. And if there is a source you can fix, you want to get to it as quickly as possible. All right, now the case presentation. Next slide. We talked about this patient. This was our ruptured lady who was sitting there. I think any of us who have done obstetrics have had patients like this in the past. That's why they chose it. Next slide. We know what she had. So she had a 22,000 white count. She had a screen positive, but no sepsis confirmation, they said, because she had no fever and no clear source of infection. She had an elevated white blood cell count 2 days before that, which they said was due to beta meth. 2 hours later, they did a cesarean. Next slide. the kid was 1 out of 8. The sepsis was clearly affecting uterine perfusion. She rapidly progressed to that temperature. Every one of those is a screen positive. She had a mean arterial pressure less than 65. Obviously, if a patient's had a spinal, someone's going to want to say it was the spinal. You need to be really careful. You call the rapid response team. They gave the IV fluid bolus. They gave Zosyn, because even though she was ruptured and you think the organism's going to be, oh, groupie strep or E. coli, you don't know. Her lactate was 9. That's a pretty high lactate. 4 is very worrisome and highly associated with lethality. Remember, 2 fires for definite sepsis. She's oliguric. Next slide. She was bleeding at the incision site. What does that usually mean? Bleeding at the incision site usually means that they're getting a coagulopathy. She was taken to the ICU. She was continued on broad spectrum antibiotics. She had supportive care. Final diagnosis, septic shock due to chorio with bacteremia, grew both group B strep and E. coli. This is a pretty classic one. No fever initially, but she met the screening criteria for sepsis. I'm going to make a bet that if we had data on the 4 days before that, she'd have met screening criteria then. With the lack of sepsis being confirmed, again, missed opportunities for earlier treatment. People look for reasons to explain things away, okay? The mental status changes. She's really tired. She just delivered. I didn't want to wake her up. Her white count's up because of this. Her urine output is low because she just delivered. You don't want to explain anything away. Don't look for reasons to say things are there other than sepsis. If it doesn't pan out, you can always say, well, it was something else, and take things back later. And then these are an appendices toolkit. These are all available you'll see on the next slide. I think that there are really good ones here. Go back one slide real quick. I think the ones that are really good here are accommodations for special populations, maternal sepsis evaluation flow chart, how making sure they do respiratory rates appropriately. I always find it amazing that most patients on an OB floor all have respiratory rates of 22. Oral temperatures versus skin surface temperatures, debriefing forms, and sepsis drill scenarios. Obstetric education for RNs. And then the one thing that I don't see down here is good education for intensivists and a rapid response team. I think that needs to be institutionally derived. And then the next one is where you can go to find all these. Next slide. There you go. That is a great website.